Screen visible?
Yes, sir.
Yes, sir.
Yes. So this is an early marker of ischemia, the diastolic dysfunction, because it indicates that cardiac muscle is not receiving adequate blood supply. And most of the time we pay attention to the ejection fraction, which is the systolic function rather than the diastolic function, which whenever a patient is referred to us for pre-anesthetic checking. And LV diastolic dysfunction, or it's also called the heart failure. It's not a usually significant problem in daily life, but patients suffer from space intolerance, dyspnea, or pulmonary edema. Then only it becomes very obvious or over that we find that their diastolic dysfunction is very obvious. And they often end up with an acute failure and come up to the intensive care unit with unstable vital signs, with florid pulmonary edema, which is not responsive to the normal IV treatment with supportive drugs. And this sort of LV dysfunction, regardless of the LV systolic function, may result in surgery-induced. It can be precipitated during surgery when there is an adrenaline stimulation or anesthesia-induced sympathetic attenuation, resulting in the lengthy stay in ICU or even death. So, if you are not very much aware of this particular pathological condition, this is the reason why you just look at the ejection fraction in the systolic function. It is 50, 55. You think patient is okay. And then you take up the case and intraoperatively you find the patient suddenly going in for pulmonary edema. So what will be the earliest indication that the patient is going in for pulmonary edema when you paralyze and control the ventilation and maintain anesthesia?
Poor compliance, maybe.
So how will you detect poor compliance?
Plateau pressures will raise.
Increase in airway pressure, not only pressure, increase in airway pressure without obvious bronchospasm. So when you auscultate, you find there is air entry, but the bag becomes tighter if you are manually ventilating, or if the patient is on ventilator, you find the airway pressure gradually going on increasing, and suddenly you will find there is no air entry at all, and there is fluid coming out through the EP tube, flooding the whole circuit. That will happen. Okay. So early rise in intra airway and transit airway pressure without a bronchospasm, that is the earliest indication. And if the patient is under regional technique, what will be the earliest sign? Patient is conscious, patient is not being intubated or ventilated. You are doing a herniorrhaphy in a patient with a diastolic dysfunction under regional technique, central nervous urachal blockade. What will be the earliest sign of sympathetic pulmonary edema?
They can't maintain the supine position, sir. There will be off.
Tachycardia and shortness of breath.
Even before shortness of breath, patient lying supine, even before shortness of breath, level has not become very high. You find the level is only up to 3 umbilical level. And patient, what will be the earliest indication that patient is likely to go in for pulmonary edema?
Tachypnea, sir?
Not tachypnea. Prof. Patient will start having. Like that, if the patient starts having a cough for which you cannot find out a reason, You auscultate the bases, you will find the fine creps occurring. Okay, so that is even before they develop severe tachypnea, they desaturate, then they have florid, frothy sputum or secretion. The earliest will be cough. A patient who has not had a cough in the preoperative phase, if they develop a irritable cough, you ask them, they will be talking nicely. என்னமோ தெரியல எனக்கு இருமல் இருக்கு. That they இருமனம் போல இருக்கு. That sensation to clear the small secretions that is collected. That is the earliest indication. So you must be very watchful in a conscious patient if they start coughing in between, or in a patient who is anesthetized and undergoing controlled ventilation, you must check for the airway pressures, which will be rising in the absence of bronchospasm. So that is the main important thing about the diastolic dysfunction, which you have to know. And that is the reason why we are talking about it more nowadays, and we are also asking questions for you to write in the examination. So diastolic dysfunction indicates impaired filling of left ventricle at low pressure and abnormalities in diastolic distensibility, filling and relaxation. It is associated with maybe patient may be a chronic hypertensive patient, diabetic or ischemic heart disease patient. In these conditions, it may happen. And it is diagnosis confirmed can be from the cardiac catheterization or Doppler examination of the left ventricular diastolic filling and increased LV diastolic pressure, that is more than 16 millimeters, found out by the TO or by the Doppler studies, will tell you about this particular condition. And in the preclinical state, and there is compensated, there is an increase in the left atrial pressure because the left ventricle is not relaxing adequately. The normal pressures are not able to allow the blood to flow from the left atrium to the left ventricle. So the first compensation will be without atrial contraction, the pressure in the atria will start raising so that it can push the blood from left atrium to left ventricle. And that period, patient will be totally asymptomatic because the left ventricle gets adequate filling done by the raised left atrial pressure, and cardiac output is maintained. But the ventricle gradually becomes stiff and thickened, and the cavity becomes low. When the muscle starts enlarging, it occupies more space. When the left ventricular hypertrophy occurs, the muscle is able to contract powerfully. That will preserve the systolic function, but the cavity becomes smaller because the enlarged muscle mass reduces the left ventricular cavity size and the filling is becoming decreased. So echocardiographic or angiographic evidence and accompanied by symptoms and signs that can be confused with chronic obstructive pulmonary diseases such as exercise intolerance, exertional dyspnea, and pulmonary edema with normal EF, that is considered as diastolic heart failure. Okay. Patient will give clear history that after walking about 10 steps or 15 steps, they become a little breathless. That exertional dyspnea will be there. On and off, they will say, I am having a wet cough, which is mistaken as a pulmonary infection and treated with antibiotic unnecessarily. And very late stages only, you will get the raised JVP, enlargement of the liver. All features of right heart failure will happen very, very late stages. Okay? So DHF can show a normal ejection fraction. This is called the heart failure with normal or preserved ejection fraction. And in extreme cases, it will be associated with systolic dysfunction also. So what are all the criteria to name a patient as having a diastolic heart failure? That will be one signs and symptoms of congestive heart failure like pulmonary edema, effort dyspnea, orthopnea. Normal or mildly reduced EF, that is the preserved ejection fraction, and echocardiographic and Doppler method shows a abnormal LV relaxation with a LV end diastolic pressure of more than 16 millimeters of cardiac catheterization. So henceforth, when you see an echocardiographic report, please look for these values Don't just go by the cardiologist reporting grade 2, grade 3 diastolic dysfunction. Look what will be the, because these details are given in a full echocardiographic report. They will give the LV EDP pressure, the LV size, the thickness of the wall, everything will be given. So make sure that you go through these factors to find out the abnormal LV relaxation. And finally, the biomarkers like NT-proBNP also increases. So these are the three things which are considered as the important criteria for diagnosing. And all the three criteria are required for diagnosis. So even one of them may be slightly absent, then it is considered as a lower grade and not as a full-blown diastolic heart failure. And when you do the echocardiographic result, it measures actually the two peaks will be there. The E is the early diastolic filling. What Richard explained as the 4 stages of the early filling is, one is the period of isovolumetric relaxation. Second is the early filling. Third is the diastasis. Fourth is the atrial contraction. So during the first phase itself, lot of blood flows from the left atrium to the left ventricle, and that is seen by this particular high peak wave. Then it becomes, there is a supplementary or smaller fraction of filling takes place by atrial contraction. So this is at the mitral inflow. You will find this is the picture of a normal diastolic function. That is called the E by A ratio. Whereas if you look at the mitral annular, that is the valve has got a ring through which the valve leaflets are attached. So this annulus moves during the contraction or during the actions of the mitral valve, and that movement comes as a reverse deflection in the echocardiography. So that reverse is called the E by this is E prime. So this is normal E. This is called the E prime, or the, when you put an apostrophe like thing, it is called E prime. So this ratio, when it is less than normal, I mean less than 10, it is called normal function. And once it increases more than 10, and then it is considered as mild and severe case consideration. So this is the actual method of identifying, and we must learn to look at the pictures of the echocardiography given along with that, and repeatedly seeing these pictures and noting down these values will help you to identify diastolic dysfunction much faster than your normal. And in preclinical diastolic dysfunction, hypertension, hyperlipidemia, coronary artery disease, and renal dysfunction are also quite prevalent. So in patients with all these comorbidities, you have to look for specifically the diastolic dysfunction. And the asymptomatic patients are common without heart failure, as with a increasing age also. This is a very common condition. And this alone may not predict the outcome. Now, this is again as described by Risha. It is the 4 stages of normal diastole: isovolumetric relaxation, rapid filling or early filling, diastasis, and the atrial contraction. And during this relaxation period, the mitral valve closes. Now the main mechanism by which it is happening is calcium is removed from the troponin C, which has caused the actin-myosin complex to come together to cause the systolic function. Once calcium is removed from that, the actin-myosin complex again separates and the muscle relaxes. This is what is happening, and the calcium has to be pushed back into the sarcoplasmic reticulum. That is the main mechanism. And if this process is not happening properly, what happens? The actin-myosin complex is not releasing, and it remains partially contracted, and that stiffness ensues. And the relaxation of the LV starts during early systolic period itself, and because it starts with the dissociation of actin myosin cross bridges and ends up in the relaxation, and contraction is immediately, this indicates the relaxation and contraction is intimately coupled. Now, what are the risk factors for diastolic heart failure? In the preoperative anesthetic evaluation, patient may have history already been diagnosed by the cardiologist to have a diastolic heart failure. If the patient is a patient in more than 70 and belongs to the female category, you have to think of that. Patients with diabetes and CKD look for this particular dysfunction. And any recent weight gain in the form of fluid overload or obesity, systolic hypertension with increased pulse pressure of more than 70, and jugular venous distension, cardiomegaly or pleural effusion on radiography. Sometimes patient may have a very small amount of pleural effusion which is ignored or which is not properly noted. And previous history of coronary artery disease, left ventricular hypertrophy or repeated atrial fibrillation, or patients who may have a normal EF but left atrial enlargement LVH in echo report, but also to be given due consideration. And if you check the BNP values, they are high. Exercise intolerance or exertional dyspnea history is there. And ankle edema, bilateral peripheral edema is also not to be ignored, and you have to check for diastolic dysfunction. Now, new guidelines that have been formed for diagnosis based on transthoracic echocardiogram and transesophageal echocardiogram intraoperatively, and the perioperative management of these patients are, you must make the dysfunction corrected. How do you do that? This is because renin-angiotensin also system plays an important role in the development of diastolic heart failure, particularly in the event of myocardial remodeling and fluid retention. So AC inhibitors and angiotensin, ARBs are mainstay drugs which are given, and also aldosterone antagonists like are also proposed to treatment. And drugs for the treatment of pre-existing heart failure, arrhythmias, hypertension, ischemic heart disease like diuretics, beta blockers, calcium channel blockers, and antiplatelet drugs are all given to maintain the other comorbid conditions. And the intraoperative BP control is very important. That is, the systolic BP must be within 10 to 20% of the baseline value, and pulse pressure should be kept below the diastolic blood pressure. That is very important. So an increase in pulse pressure, that is the gap between systolic and diastolic, if it becomes high, then there is a severe ventricular wall stress. So you follow what is called the rule of 70, it is useful, where you can think of controlling the BP if the age is more than 70, diastolic BP more than 70, heart rate more than around 100, and pulse pressure less than 70. And drugs with positive leukotropic effects are often invaluable in circulatory failure. And the two drugs that are commonly used are milrinone, which is a phosphodiesterase 3 inhibitor, and levosimendan, which is a calcium channel sensitizer. So these two drugs are specifically to treat this particular condition. And perioperative precipitating factors for this are shivering, anemia, hypoxia, electrolyte imbalance, deterioration in diastolic dysfunction, myocardial ischemia, hypovolemia or hypervolemia, tachycardia, arrhythmia other than sinus rhythm, and sympathetic stimulation because of pain, anxiety, or other causes, and postoperative hypertensive crisis. All these conditions can result in diastolic heart failure. So henceforth, make sure that when you read the echo report, look specifically for diastolic dysfunction, and if it is written as grade 2, 3 or more, make sure that you don't precipitate any of these causes in the postoperative or perioperative period to prevent the patient from going into for failure. So these are the points that you have to remember with regard to